Hello, everybody. My name is John Tonin for Ignite News, and today we have a special show for you. I'm joined by Alan Sharpe, who works with the St. Joseph's Health System International Outreach Program. So, Alan, what's your role with the IOP?
I'm responsible for fundraising and what we call friendraising. So, trying to recruit donors and supporters that would support the ministry that we do overseas.
So, Alan, can you give us a little bit of a history about the International Outreach Program?
We have been around for 25 years. We were started back in 1985 by the Sisters of St. Joseph. They're the ones that started the St. Joseph's Health System way back when. And it was a program that sent doctors and nurses overseas to train doctors and nurses and also donate equipment and supplies in countries where there's a shortage of doctors and a shortage of healthcare capacity. Around 5 years ago, we became a registered nonprofit of our own. And so we're now responsible for raising our own funds. We don't get any money from the Sisters of St. Joseph anymore. And we train doctors who train doctors in 3 countries, Uganda, Haiti, and Guyana.
Awesome. Let's meet our first doctor, Dr. Clement Okello.
There's a place in Uganda called Abim District. Is in Karamoja. I work at the capital, that is Kampala, Mulago Hospital, and specifically Uganda Cancer Institute. While I was at the Cancer Institute, I was working as a physician. The highest level of training I'd achieved was residency in internal medicine. There are categories of specializations for the doctors after the medical school. One can go to do surgery, that's cutting. Mm-hmm. The next one is obstetrics and gynecology, that's women. And then the other specialization is pediatrics for the children. Then the medical conditions in the adults that do not necessarily require operation, those ones, the specialists study internal medicine. Blood disorders, for example, that's what I've come to study here. The fact that there is a big gap in the field of hematology, and especially at the Uganda Cancer Institute, and the interest that I had to pursue this discipline, I was identified, and then I came to McMaster University. My family being back home is a motivation for me to really study hard, go back home, work hard for them. And they always tell me, hey, read hard, and I tell my daughter, hey, I'm reading, you also read. There's a lot that I have to take back to my country in terms of the skills I'm going to learn from here, given the fact that this discipline is not taught in itself in Uganda. Uganda is such a small country with a population of about 36 million. And that's the population, I'm told, almost is of Canada, but Canada is so huge with all these medical workers, and the ratios of the doctors to patients back in Uganda is overwhelmingly. The healthcare professionals are very few. What I learned here that I would take home definitely is to actively look for the disease, tell the people to come for regular checkups, because of most diseases here are also caught up pretty early because of these regular checkups, which is not routinely done back home. Anyone else who would really, if they ask me whether they should join IOP or not, I think I would say I will not hesitate to recommend them to come to IOP.
We're rolling as well. So, Alan, what are some of the goals of the IOP when they bring a doctor to Canada?
Well, first of all, you need to understand that the reason we bring a doctor to Canada is that there's a doctor shortage in the developing world. There are, in some developing countries, there are 100,000 people and there's only one doctor. So that's like Hamilton having 5 doctors. So there's a shortage of doctors, and there's especially a shortage of doctors that have a specialty or a subspecialty. For example, many physicians in the developing world are just general practitioners. There aren't that many specialists in such things as pediatrics, surgery, hematology, nephrology, and there are even fewer subspecialists. So you wouldn't find many pediatricians that specialize in children's cancers. So that's why we bring those physicians to Canada from Uganda, from Guyana, and from Haiti. We bring them here to learn a specialty such as pediatrics, or a subspecialty such as pediatric nephrology, which would be kidney failure. So our goal here, when we bring over a doctor, sometimes we bring a medical student So they'll come here for a 6-month residency, the same way that a medical student in Canada would do a residency. It might be a residency in obstetrics or pediatrics or surgery. Then when they become a doctor, a licensed doctor, we may bring them back again, or we may bring someone else who comes for what we call a clinical fellowship. They come for a full year to study a subspecialty. So our goals are twofold. We want to train them academically. So while they're here at McMaster, we have a partnership with the McMaster University Faculty of Health Sciences. Our goal is that they learn academically, so they have the academic knowledge that they need to go back to their country and teach others what they've learned. So the International Outreach Program, our goal is to train a doctor who trains a doctor. It doesn't make much sense for us to train one doctor who goes back to Uganda and just practices medicine. What we want to do is exponentially increase the capacity for healthcare in Uganda and Haiti and Guyana. So we train a doctor academically who goes back to Uganda, for example, and then has a faculty position at the university and teaches other doctors.
So we're going to meet our next doctor, and this is Dr. Peace Bagasha, who is studying nephrology.
Bagasha Peace. I'm a medical doctor from Uganda. I work in Mulago Hospital, and I work with the nephrology department. So the nephrology department is basically people who take care of any kind of kidney disease. You imagine in Canada, for example, so 1 in every 4 people who have diabetes will end up with kidney disease. Yeah. So and diabetes is like huge. Like so many people have diabetes. So in Uganda, we have not only diabetes and hypertension because those are lifestyle illnesses. We have those, but then we also have a lot of infections, a lot of HIV. Uganda is like one of the top countries when it comes to HIV, like pandemic. So HIV infections, and then on top of that, there's like out of a population. So Uganda has a population of 34 million, which is the same as Canada itself, and it's just the size of like 4 Ugandas will fit in Ontario. So Uganda is really small. It has that much population and that much density. So for a population of 34 million, we only have 4 nephrologists. So nephrologists are the doctors who treat like kidney disease, and there's only like 4. So even if it was small number of patients compared to Canada, still the numbers are really, really overwhelming for the 4 doctors who are looking after the kidneys. So it's a huge, huge, huge problem for us. The fact that there are very few patients who come, because I do the nephrology clinic, and nephrology is almost like a death sentence for us. Like if a patient has end-stage kidney disease, it's almost like a death sentence. They have to pay. The difference is that they have to pay all their bills, all their medical bills. You know, Canadians, you're really lucky. Your government pays for you. You know, so for us, they have to pay for dialysis. Dialysis is really expensive, and they have to pay for dialysis. So for many of the patients, it's like a death sentence, really. And the fact that there's no doctors to really help them through it makes it, I think, even worse. So we actually have a lot of Ugandans who are doctors, but the problem in Uganda is that the pay is not too good. So many of them, once they get their medical degrees and they realize that they're not getting so much pay, they will leave Uganda and go to other countries to work in other countries. They will come to Canada, they will go to Australia, they will go to other places where they can get better pay. So that is always a very bad thing that happens. Most importantly for me, the thing that I'm going to take back the most is the fact that learning that, even if you have very many resources, there's still so much more you can do. And many of the things that we are doing here, we can still do in Uganda, despite the resource limitations. So there's still actually a lot that I'm actually going to be able to take back home. Yeah, simple things that you guys are doing, which can actually be applied without thinking about resource limitations.
So aside from learning the curriculum, they live in Canada for a year. So how important is it for them to learn a little bit about Canada as a country while they're here?
Well, they kind of learn it by default, unfortunately. Many of our doctors and residents, they got off the plane in Canada. Sometimes it's February, it's -20, and it's a big, big shock for them. If they're coming from Uganda, where it might be 30 degrees centigrade, and then they come here and it's -20, it's a big shock. So we help them with clothing, we help them learn the culture and learn how the buses work. Some of them have never taken a bus, some have never even been in an elevator. And so we introduce them to Canadian culture. Most of our volunteers do that. It might be Christmas time. They might be invited over to someone's home for a Christmas dinner. Some of our volunteers take the doctors and residents to outings, parties, Niagara Falls, movies, introducing them to Canadian culture, even out to restaurants to sample traditional Canadian cuisine.
It's funny you said that because we took Dr. Anthony Batty, a pediatric nephrologist, out for his first Canadian meal. Take a look.
And I don't understand the science of a burger. So, what's the topping, when is bread, and what's in the middle?
That's up for interpretation.
Yeah.
Bun's gonna go on top though. And then usually like your patty, and then like the toppings on top of the patty.
Okay. This side is where we are looking for the patty, and then.
Okay, your patties are right here. Yeah, they have a chicken patty here.
Oh, it's already made. Okay.
Or you can get ground turkey.
Chicken.
Chicken.
Chicken would work.
The waitress arrives. Time to get that first Canadian meal cooking. Yeah. And this guy's getting a poutine too. Because he's never had one before.
Oh, you have to have one.
I should.
Okay.
Yeah.
And what
Good
kind
idea.
of burger would you like?
He still remembers what I ordered.
Oh, you need help there?
So
Okay,
there
you're
was-
getting. He's getting the chicken breast
Yeah.
Okay.
with just lettuce, onions.
Pickles, tomato.
He's never tried pickles. We put the pickles on the side,
Yeah. Lettuce, onion, tomato, pickles on the side. Okay.
and then like a ranch,
Yeah.
And a ranch.
like ranch
Ranch
sauce,
sauce.
and then bacon.
And bacon.
Yeah.
Good. Thank you.
Anything else you need on
No.
there?
Those were-
You missing?
First up, the Canadian piece de resistance, poutine.
You gotta selfie that for your kids back home.
Oh, I
Look
should.
what I'm trying.
Hey.
Before the first bite, gotta get a picture for his family back home.
Can you help me take a photo with me inside? Such they don't say I photoshopped or got it from Google.
Ready?
Yep.
Smile there. Hey man, that's a good pick.
Yeah.
Really good.
Thank you.
Facebook play picture. Worthy.
Very good.
First up, the Canadian pièce de résistance,
What do you
poutine.
think of
The
that?
Putin.
Yeah. You like it?
It is good.
They're gonna need to bring a doctor over from Uganda that deals with like the arteries and stuff. Like the joke is like it's artery clogging.
That's no. If you're in Canada, they will correct the arteries.
Yeah.
You don't have to worry. They'll unclog them.
Next up,
This gave you
Dr. Anthony Batty tries a pickle.
Feels sweet.
They're good, eh?
Feels sweet.
Essentially, a pickle's just like a little cucumber, a little baby cucumber, and they just stick them in vinegar.
Oh, and I didn't get it. I had the sweet. I didn't know it was cucumber. I knew cucumber, but not a pickle. So
It was just a way to like.
It's time for the burger, which means one more time to get a selfie.
the photo is better taken when I'm eating, when I'm holding it. Sorry. So wait a minute. So I just pour it
Dump
down.
it on there, yeah. No need to be polite. There it is.
That's it.
Yeah, that's good.
Like
Right.
that. Yeah.
Take a bite now. I'll get one of that too. Oh yeah.
Hmm.
You like it?
It is. It's nice.
Nice, huh?
Mhm.
There.
Oh.
Take another
Yeah.
bite.
Oh, another bite.
Yeah, do it.
The meal was finished and our bellies full. Batty's first Canadian meal was a success.
So, Alan, you just got back from Haiti. When the IOP travels to a country like Haiti, what are you guys trying to accomplish while you're there?
Well, in Haiti in particular, we're helping in the local hospital, which is in a place called La Pointe, which is on the very northern coast of Haiti. It's a rural hospital. They have a huge population that they serve. It's about 500,000 people. So we're there in particular to help them with their obstetrics program. They have one obstetrician who delivers about 1,000 babies a year, 3 babies a day. He's overwhelmed. He's always on call. So like 24 hours a day, 7 days a week, he's always on call to deliver a baby. So we had our team that went down this time, we took an obstetrician gynecologist with us who helped the obstetrician that they have there. His name is Oles, Dr. Oles. And so Oles had spent time in Canada with the International Outreach Program for some residency training. And our doctor from here, volunteer, went to Haiti with us on the team, and he coaches, mentors this obstetrician when he's there for that week. Works in the OR, helps him with cesareans, helps him with diagnosis, helps him with the latest best practices in medicine, kind of works as his partner and kind of his encourager. And we also took an orthopedic surgeon with us and an orthopedic nurse, and he spent time in the OR, the operating room, doing orthopedic surgery. But when he was doing it, he had an orthopedic resident, a Haitian third-year orthopedic resident. And so they worked shoulder to shoulder. The orthopedic surgeon from Canada was training the third-year resident in actual surgery in the operating room. Plus, we had a Canadian anesthesiologist who was there training the nurses in the operating room how to administer various types of anesthetics. And we also had the orthopedic nurse who was training an operating room nurse who had never done orthopedics before. She didn't know what a nail looked like, didn't know what a screw was for. Being graphic here. And so she was helping this nurse understand that when you're setting a bone or putting in a plate, this is how you do it. And so the nurse in Haiti actually got really excited about orthopedics and has decided she wants to specialize in orthopedics. So whenever we work in a country, we work long term. We don't just go there and do some training and then leave. We go there and we continue the relationship. We build the relationship, the trust, and we go there many times a year. So this was just one of many visits that we make, and we were continuing where we left off. So there's kind of this continuum of training that we do. We also have a nurse volunteer that went down there, and she's helping with the whole nursing program, making sure that they're kind of keeping up with what we're helping with them. But the key thing to remember about the International Outreach Program is we only go to a country when we're invited, and we only do the training that they ask for. And we only give them equipment that they ask for and supplies that they ask for. We don't just go there and say, we know what to do. This is how you do it. We're going to revolutionize your program. We asked them, what do you need? And they said, we need obstetrics and we need orthopedics. So that's why we went.
So let's take a look at your latest trip to Haiti.
And right now with EOP, we have a nice room because of the work that EOP helped to do in them. And so that makes a big difference here.
And now we are in a very primary care hospital in northern Haiti, where we are basically trying to help the people to build their own knowledge, to build their infrastructure so that they can take care of the large population around them. The problem is you like to do many things, and you could do many things, but and teach and improve the patient care delivery, but if you don't have the infrastructure in place, then it's very hard to do.
He said that there's lots of changes. There's a very big, a huge difference, before the IOP came and after. Especially for the surgery room, it's very different, because before it wasn't like that. But with the partnership they have with IOP, they made a great transformation into the surgery room, and it becomes very modern.
There is an operating room. There's 2 large operating theaters, which are working very well for general surgery and obstetrics and gynecology. These are the only 2 services of surgery that they can do right now. And the IOP, is working very hard right now to start an orthopedic service, because a lot of fractures, a lot of injuries arrive at the door every day.
At CMB, maternity is very important service. According to the great importance of maternal care, and according to the number of patients that we receive in this hospital.
The IOP has a working agreement with them to try and improve many aspects of functioning of the hospital and care, particularly in women's health care, in obstetrics, in maternity care, and in other areas in trauma, orthopedics, etc. So I was been working very closely with the young obstetrician that works there. He's the only one there, and so he sees me as a mentor.
Also, the training are very positive. It helps them, even if like, the trainer is not there. They all, like the surgery room staff, they can also continue to do what they learn.
And the satisfying thing is that after we leave, we see that they work on things. Things don't stand still just because we leave.
So if a doctor from, let's say, Uganda wanted to join the IOP and come study in Canada, how would they go about doing that?
Well, the key is that we work with universities. We have memorandums of understanding with universities and medical schools in Uganda and in Guyana. And so if a doctor wanted to come to Canada as part of the International Outreach Program, they'd have to go through their faculty, they'd have to go through their dean, the university dean. It would have to be approved at the university level. So we don't just take any doctor. We make sure it's a doctor that the country actually wants. And so there might be a doctor who's a real keener and wants to come to Canada and study, but that might not fit in with what the faculty wants or what the hospital wants. In Kampala, for example, the capital of Uganda, you have Makerere University, which is the medical school, and then you have Mulago Hospital, which is a teaching hospital, and they work together. And so the residents that we get and the clinical fellows that we get from Makerere University have all been vetted and approved by the university because the university decides that's what the university needs, that's what the hospital needs, that's what the people of Uganda need. And so it's kind of it's sort of a top-down approach. We work with these universities. There are 4 universities, medical schools in Uganda. We work with all of them, and throughout the year, we're talking to them. We make visits to Uganda, and we talk to them about their needs, and we kind of plan out 18 months, 24 months ahead on which physicians they would like to send. And it's really based on what they need in Uganda, what the hospitals need. And so the university decides who's needed, and then they find the best candidates for that.
So let's meet 3 of those doctors that were successful applicants to the program.
As a country, as Uganda, we need to acknowledge the importance of what the IOP has done to our country. Because I think some of these things, like the trainings that we get, are very key to first the health system in Uganda, and I believe still whether the government can afford or cannot afford, what we know is the government has not been able to do this, and these are expensive ventures. Bringing a person from Uganda like me, come to Canada, get residency, where to stay, pay for accommodation, pay for my licensing by the organizations, this Canadian Physicians and Surgeons of Ontario's licensing, pay for my insurance as a health worker. I think these are big ventures which the IOP has decided to take on. And I think they are very important, and they are helping our health system.
And, the training is good. Yeah, the teachers give you a chance to, especially in my discipline where I have to learn to do procedures, the teachers are willing to, go an extra mile to make sure they're giving you the opportunity to learn the techniques that you need to.
When I return home, because I'm basically at the training side, but I do both training and also that means teaching undergraduates and postgraduates, and I also do the clinical work. So I'm going to really try as much as possible to teach the undergraduates and teach the postgraduate. And how I'm going to do this is through the Dean of School of Medicine. I'm going to lobby for slots in both, like incorporate tutorials, because we use tutorials so that all the levels of training, they have at least some geriatric syndromes being taught.
So Alan, why would a doctor from Haiti, Guyana, or Uganda choose to come to Hamilton over another place to study?
Well, there are two things that are unique about the International Outreach Program. One of them is that our emphasis is on training a doctor who trains doctors. We don't just train a doctor to go home and practice. We train them to get a faculty position at a university and train doctors who train doctors. So we can have an exponential change in the country. The idea is that they bring long-term change. And the second thing that's unique about our program is that most medical schools that offer this kind of training to overseas residents or clinical fellows, they offer an observership. So the doctor's allowed into the OR and they're allowed onto patient wards, but only to observe. They can't touch patients, they can't prescribe medicines, they can't do any procedures, they can just watch and be quiet. Whereas in Canada, through the International Outreach Program, we have this unique program. It's unique in North America, actually, as far as we know. That is that the doctors that we take into our program are fully licensed. They're fully licensed to practice medicine in Ontario, and they're insured, so that they can do everything that a Canadian resident do. So they can draw blood, they can order x-rays, they can prescribe meds, they can deliver babies, they can set bones, they can do operations just as a Canadian resident would, which is a unique thing about our program.
And if people would like to learn more about the IOP or would like to donate, where should they go?
They should visit internationaloutreach.ca to learn more about our program, how we're unique, where we work, what we're doing. There's also a blog. They can subscribe to our newsletter. And if they wish to make a donation, they can visit internationaloutreach.ca/donate.
So Alan, thanks for joining us. That concludes our episode this week for Ignite News. I'm John Tonin.